Good afternoon, everybody. Thank you very much for joining us. This is Jeff Wilkinson. I'm a professor at Boston University, but I worked for 7 years at the Massachusetts Department of Public Health as Senior Policy Advisor to the Commissioner. And in that role, I chaired the Board of Certification of Community Health Workers in Massachusetts and have 15 years of experience with workforce promotion for CHWs. Folks, if you could please mute your line if you're not speaking, that'd be great. Our consultant team includes Terry Mason, who is late joining the call.
No, I'm on the call.
Oh, she's on. Oh, great. Okay. Hi, Terry. So why don't you introduce yourself?
Okay, so I'm Terry Mason, and I have been doing consulting and staff work in community health worker policy and workforce development for over a decade now, and I'm based in Boston, Massachusetts. Carl?
Hi, everybody. My name is Carl Rush. I'm in San Antonio, Texas. I'm a consultant in policy and workforce development related to community health workers affiliated with the University of Texas School of Public Health, and have been working with various states around these issues for about 20 years.
We're pleased to have so many people on the call, and we are together on this call, a mix of folks. There are 5 states in the learning community that we're working with, including Nevada, Nebraska, Oklahoma, North Carolina, and Louisiana. And we have representatives from the Departments of Health from each of those states, but also stakeholders from a number of those states. We opened this call up to partners of the state health departments, and so there are too many of you to invite everybody to introduce themselves, but it looks like we have representatives of health plans, community-based organizations, CHW organizations, health providers in various locations. So we hope that this will be a useful discussion, not just a presentation of information from us, the so-called subject matter experts, but from you, and that you can learn from one another. We chose the topics for today's webinar based on the needs and interests expressed by our state health department partners in each of the 5 learning community states. And so what we've done today is to put together some slides that we think will provide some cross-cutting information of value to issues that each of the 5 states is working on. All of the 5 states are at different levels of development or in different places on this road, and so that'll be an opportunity to learn from one another. But it also means that there's no real common denominator. Some of what we have put together here may be information some people know. It may be new for others. So we'll take the conversation as it goes, and we invite you to interrupt us at any time with questions. We've baked questions into this batter or into this presentation along the way, but you really are welcome to stop us as we go if you have something that's kind of a burning question, something confusing, whatever. So with that, the objectives for our call today are to define the community health worker workforce. We're going to start with the American Public Health Association definition, which is a standard for the field, but we're also going to address a variety of issues related to a definition of the workforce, and sometimes making sure that all stakeholders are on the same page with respect to how to define and understand the workforce is one of the most challenging parts of setting up a sustainable CHW workforce promotion program. The second major objective is to discuss the credentialing of CHWs, and we're going to be talking primarily about certification, but we'll put that in a broader context, and we'll talk about issues and options for certification that states, health departments, that is, and their partners can and should look at. And finally, we will open this up to a free-ranging discussion about how those issues relate to the work that you're doing in the learning communities. And if you are a partner and not a state health department representative on this webinar, you are equally welcome and strongly encouraged to ask anything and offer anything that comes to mind. When we think about the CHW workforce, it reminds us of the parable of the elephant and the visually disabled observers. And depending on where you stand around or on this beast, this can look like a very different animal. So we run into this, and in defining the CHW workforce, a lot of people think it's a CHW is a different thing. That's complicated by the fact that there are some 50 different job titles that are associated with CHWs. So we're going to get into that a little bit. We want to use as our reference the American Public Health Association definition of community health workers, which dates back, I believe, to 2001. Carl, is that right? You know?
Sorry, I'm on mute. This is actually in a policy statement that was adopted in 2009, but the definition was created earlier in advocating with the Office of Management and Budget to create a standard occupational classification for CHW. So that would have been around 2006.
Okay, thank you. The APHA definition is that a CHW is a frontline public health worker who's a trusted member of or has an unusually close understanding of the community that they serve. And that is really core, and we're going to emphasize that all along because it gets into questions of how to educate, train, choose, employ CHWs. These are people from the community. They understand the community, and they have trusting relationships that enable them to serve as liaison, links, intermediaries between health and social services and the community to facilitate access to services and improve the quality and cultural competence of state delivery. I won't read the rest of the slide, but we'll go into the importance of this full definition. There are other definitions of CHWs, but we think it's important to use this one. It's being promoted as a national standard. Many states are using it, and we think that it effectively captures this core idea that CHWs come from the communities they serve. That relates also to what makes CHWs particularly distinctive from other health workforces and what makes them effective. Their expertise is based on shared life experience and usually shared cultural background with the people in the communities that they serve and typically come from. CHWs do not provide clinical care. That is, they do not diagnose or treat injury and disease. They are, in some cases, involved in providing clinical services related to preventive screening. This is relatively unusual, but we do see CHWs sometimes trained to take blood pressure or pinpricks for diabetes, but generally that's not done, and they don't provide clinical care per se. They often and typically don't hold other professional licenses. That's not always the case. But licensed clinicians who work in community health are not automatically CHWs. And this is an important point. I mean, you have nurses or social workers who do community-based or home-based visiting or care, parent educators. They may work in the community, but that doesn't make them a community health worker. If they don't share the characteristics of the community, if they don't have that community foundation, then we would not call them a community health worker. And CHWs may have other licenses. You can have CHWs who are social workers, for instance, but that's not true for most CHWs. They tend to spend more time with people in the home, in the community. Some states even include a functional definition of CHWs that stresses that work. And they tend to spend more time in clinical settings where they work as well. This is part of their value in healthcare and integrated care teams. They can actually spend time with people in ways that licensed clinicians are often not able to do given our payment systems. They are key in addressing social determinants of health, issues related to food security, transportation, housing quality, employment, education, transportation, things that affect health and that may provide barriers to health and be causal factors in either disease itself or in people's ability to adhere to prescriber orders or physician recommendations. So these are the folks who are working upstream in the health system. They share trusted relationships, which is part of the power of their work. And Carl coined this term, the 3 C's of community. They're connected, they're credible, and they're committed to their communities. And our CHW partners really stress that their core values are based in equality, health equity, justice, and empathy. So let's look a little bit more deeply now, and we're going to have Terry take us further now into looking at where CHWs work, some of what they do, and et cetera.
Can you hear me?
Yeah.
Okay, because I wasn't sure if I was on mute. So what Jeff was saying is also reflected in the variety of job titles that represent community health workers. Community health worker was a term created to serve as an umbrella term to capture a lot of these other proliferating titles that community health workers have in specific jobs. And this was a term, community health workers, that was created by leaders in the field of community health workers. So the field took the lead in creating this umbrella term themselves. And you will recognize a lot of these titles. They're very common. Some of them have community in them. Some of them don't. You can see that community health educator, outreach is a common term, outreach educator, because community health workers have always done outreach of various kinds. Family advocates, youth outreach workers, peer leaders, peer advocates, street worker, enrollment worker, patient navigator. Some of these are more complicated to clarify than others. Community health representative, which is historically the kind of community health worker that works with in tribal health systems. And promotores de salud, which is just the Spanish language term of what essentially is a community health worker. And so it's crucial to be aware of the community health worker umbrella terminology and what the key features of it are, as Jeff was trying to point out, because otherwise the variety of terms, and they are proliferating now in health reform again. I just heard for the first time of a term, community nutritionist, who really are community health workers. So it's very important to get a grasp on the core principles of this field. Moving to the next slide. Am I supposed to do this move?
I've got you there.
Okay, you're doing that? Okay. Whoops, let me find my slide. The next slide, again, there are a diversity of settings, organizational settings, and community settings where community health workers work. Sometimes they work in multiple settings. In fact, often they do. So increasingly, hospitals have been employing community health workers. Community health centers have commonly, historically, been employers of community health workers. Managed care organizations have, in various states, employed community health workers. Substance abuse service providers, some community health workers employed there, and it's another discussion to talk about the differences between the peer workers who are coming from the behavioral health end of the field and the community health workers who tend to work more through the public health realm. But those boundaries are also beginning to blur a bit. But in any case, community health workers do work in behavioral health settings, and increasingly they do. State and local health departments are very common employers of community health workers, depending on the state. Of course, a huge employer are community-based organizations of a variety of kinds, whether they're migrant programs or they're geared to a particular ethnic community. Public housing is historically, there have been community health worker residents of public housing who do a lot of prevention and other kind of health education work in their own communities in public housing. And schools and school health programs have also employed community health workers. So it's not a simple picture to just say community health workers work in community health centers or something, but they're increasingly working in a wide variety of organizations. One key thing to say is that it's generally a best practice to make sure that community health workers, even if they're working in hospitals, for example, to have some flexibility to work outside the four walls of where they're working, because that has been a key feature of what makes the field effective.
I'd just like to interrupt, Terry. I'm sorry. Somebody, we can hear you on the line. Would everybody please put your line on mute? And I think that'll help everybody. All right, Terry.
So that's really it in terms of the settings.
So we're looking at the diverse issues slide now.
Yeah. Isn't that you? Oh, no, that's me. Oh, I'm sorry. I didn't realize I was talking about this one. And the same thing. I think the key word in this field is diversity and flexibility and a holistic approach, which means that community health workers work on a variety of health issues as well as addressing the social determinants issues related directly to health and ability to access health care. So historically, community health workers, I think, emerged working a lot in HIV/AIDS and sexually transmitted infections and these infectious disease areas as a part of the HIV AIDS, prevention movement, which was so huge. Also, maternal and child health work is something that community health workers have done for decades in doing home visits and preventive care with maternal and child health populations. But chronic disease has taken on a larger role over time as health reform has merged to the fore and concerns about the high cost and the heavy burden of chronic disease in this country and on the healthcare system. So increasingly, community health workers have been trained to work with a variety of chronic diseases. The asthma community health worker home visiting model is a very strongly evidence-based model. Increasingly, so is diabetes. And all of the other major chronic diseases mentioned here. And community health workers have been working on violence issues in communities as well. So whether it's youth violence or suicide prevention or domestic or sexual assault, community health workers have been employed in all of those areas. And you can see the others. A lot of preventive work, tobacco, nutrition, lead poisoning, early intervention. So it's a hugely, and I would just like to add that also while community health workers may be working particularly in one of these fields or other, it doesn't necessarily mean they're highly specialized because one of the points that I think we'll be making in this whole presentation today is that there is a core, which is a kind of a generalist core of what community health workers are able to do and not necessarily just be a specialized health worker.
Thank you, Terry. Carl, there's a question that came up, and I appreciate you answered it in the little participant feedback box, but I think it's important enough I want to invite you to address it as you're discussing roles and skills.
What is that?
Sure, glad to do that. And I'm okay. So the question was, for purposes of credentialing, do we need to identify a common name for CHWs? I think what referring to here, and we'll get back to this when we talk about certification in more detail, that we're really talking about an occupational category, and so or an occupational group. And certification does not imply that an employer must use community health worker as a job title. They're free to when they offer or open a position, they can use whatever job title they wish, and there may be compelling reasons to use a different job title. But what would be helpful, I think, and we encourage people to do this, is that employers be encouraged to say, here's a job description, here's the job title. We consider this to be a community health worker position, which may be that it appears somewhere in the job description that it's described as a community health worker position. So I hope that's helpful as a response.
And
so I'd like to pick up. Go ahead.
We can get into this in later in the web books if you want to pick up on that, Dean. Sure.
So what I'd like to do, the roles, and there's a subsequent slide talking about the skill requirements. These are the product of an initiative called the Community Health Worker Core Consensus Project, or the C3 project. And I'm not going to go into great detail on this, but what you see on this slide are the 10 broad categories of activities or roles that community health workers commonly perform. And as Terry just said, that doesn't mean that a specific job is asking community health workers to do all of those things. It may be focused on, I think we had another comment before about connecting people to health insurance, for example. That may be the primary focus of a funded community health worker position, as access to health insurance. And that's perfectly legitimate, but the activities involved, or the community health worker ends up exercising more of their roles than one might think. For example, if you're talking to someone about applying for coverage that they might be eligible for, that many times the most salient issue to that individual or family is something else like housing. And so being able to help connect folks to that is important. I'm not going to go through these roles in detail. There are documents available that, and many of you have them. There are documents that are available that go into a lot more detail in these in each of these areas. But one of the things that commonly comes up as we talk about the roles that community health workers play, or the activities that they engage in, you will hear a response from some stakeholders, or you may be thinking this yourself, that, gee, we have other folks who do that, or that, well, hey, social workers do that, or nurses do that. And I want to acknowledge, and I think we all need to reflect on this going forward, is that, yeah, there is some overlap between what community health workers do and what some other professions do. There is no question about that. So there are two issues related to that. Where the overlap exists, number one, the community health worker should not be doing any specific activities that are legally required, for which they are legally required to have a license. So there are clearly limits to what the community health worker can do. As Jeff said, most community health workers do not have a clinical license. And the definition of the role of the community health worker in policy, it usually has language to the effect that they may not perform any activities for which a clinical license is required. So that's true. But there are three issues. One is that many of those activities that overlap, by definition, they don't require the level of licensure of a registered nurse or an MSW level social worker, but they do them anyway. And there is a legitimate question for that organization as to whether that's the best use of that licensed professional's time. The third issue, though, and we'll come back to this, as Jeff alluded to, we're planning another webinar talking about the value of community health workers. And there are some important capabilities based on the characteristics that Jeff outlined, some important capabilities that community health workers add to public health and healthcare based on the nature of their work, based on relationship, for example. Some unique capabilities that are increasingly seen as valuable to the new structures that are emerging in public health and healthcare. And so we'll come back to that in more depth in the subsequent webinar. But what I'd like to say is that these roles and the skills that follow on the next slide, I'm going to go ahead and advance to the next slide, that these are presented to you here, and they are presented by the C3 project as the starting point for a conversation, which is, and the intent of the C3 project is really to engage people in dialogue with community health workers and about community health workers based on a common starting point. So that this list of skills, and if we have time later on, we can get into discussion if you have specific questions on any of these skill areas. But the idea is that at least we can start from the same point in terms of that conversation. And indeed, a number of states have used the recommendations of the C3 project as a starting point in consideration of role definition and skill requirements for the purpose of certification. So you're certainly invited to do that. And again, it's intended as a starting point for that dialogue. So with that said, I'm going to turn this back to Terry to open it up for a little more discussion.
Okay, great. Thanks, Carl. So that's a lot of material thrown out there in this area that people have always a lot of questions about, which is defining this field and figuring out what's core to it and how a lot of job titles relate to it. So is there, taking a pause for a moment here and finding out, is there something in this presentation that to this point was surprising to people or raised some issues for you that made some of these comments we've made controversial? Please speak up if you have some comments or thoughts about that.
More generally about workforce definition as it applies to the work you're doing in your states and organizations.
And we should be able to. This is a large group, but if it doesn't get too confusing, just unmute yourself and please proceed to ask your question.
It seems likely that there are some job titles or terms for unlicensed health workforces that you guys are probably thinking about and wondering how they pertain to this definition. Are there problematic ones that you're grappling with in your state now?
I can go. One you mentioned, which I hadn't heard of before, the community nutritionist.
Mm-hmm.
Because I am a registered dietitian nutritionist, that one kind of, I wasn't sure if that meant it was, because I sometimes call myself a public health nutritionist, so that one kind of confused me, or I could see how it could be controversial if the person wasn't an RD.
Right. Yes, as I say, I just heard that one myself, and we're still investigating that. I really used it more as an example of how terms are cropping up now as health reform is proceeding, and people are starting to invent new terms and new categories, and it's important to try to figure out. And I guess I should say we're still not sure if these people really are community health workers, but someone wrote in to the health department here asking, if this was a community health worker that they had some training for, and so on. So yeah, it's just, I agree with you. It's a question mark.
Right. Thank you.
Yeah.
We've had a request. We've had a request that when you want to ask a question, if you could please identify yourself so everybody knows who's talking.
And I Hello. Sorry, that was Kate from Louisiana.
Great.
Hi, this is Brenda from Nevada. I work with a promotores de salud, and oftentimes as a promotora, I think we have a natural heart to just help in whatever we can. However, one of I don't think you mentioned, but I did want to point out that could be seen as along in the community health worker are peer educators, or educators who are teaching their peers through there may be some peer education programs in schools. There may be some peer education programs in community health centers that are also acting as quote unquote the tradition of like the umbrella of community health workers. And I think that is something that we should start considering or thinking about, is reaching out to young people and how we can include this in this discussion as well.
Yeah, do you want to handle that, Terry?
It's a great point, and I think I think you should handle it. I would just say I agree with you. I think that's important. But Carl, you probably have something more to say.
Well, it's a great question. Thank you for raising it. And there is some discussion about whether peer educators really belong in the community health worker category. If you recall, Jeff talked about in the definition the understanding of the community or being part of the community. The term community can be interpreted in different ways, and if you define community as being the community of recovering addicts, or the community of people who are engaged in self-management of a chronic condition, that life experience is also relevant, and so peer educators are in that role because they relate to the lived experience of that peer group. So I would just say that the skills that are required to be a peer educator are very much the same, for the most part, as those for community health workers. The duties may be a little different, but it's a worthwhile discussion to be had within your state, and there are some states that are explicitly classifying peer educators or peer support workers as being part of the same occupational category. Jeff, did I hear you start to jump in there?
Yes, you've addressed that. I think I just wanted to point out that the slide where we showed some sample job titles was just that, samples. There are in Massachusetts there was a study that documented over 50 of them, and that's not uncommon. There's been other research talking about it. So it was a great point. Peer educator is a really crucial activity and job title. We didn't try to list them all. I also want to say that there's a very robust discussion going on in the participant feedback box of the webinar. And while most webinars are structured so that people who are listening in have to do that, they have to listen in, we really would like to encourage you to speak up. And so for people who have put questions and observations on the participant feedback, I won't call you out by name, but if you're typing stuff, I'd invite you and encourage you to unmute your line and raise some of these questions or make some of these points. It'll be interesting and more fun and more valuable for all of us to do this interactively.
Hi, Julie from Nebraska. Somewhat concerning when you see community health educator listed as a title as being someone that's a CHES, I think that gets confusing with our roles and in that and the certification process too.
Mm-hmm.
I'm not sure I understood the point. This is Terry.
Oh, I'm saying, especially in our state,
yeah,
we have what I would consider a very professional level community health worker. We have almost more folks that are somewhat at a professional level with the title of community health worker. But as someone who's a health educator and a certified health education specialist, I think sometimes we're seeing the health worker role evolving to a higher level, which is can get confusing. And I've worked with health workers for years, so they can do things I can't, but I can't put that I'm a nurse when I'm not a nurse. Do you see what I'm saying?
I think so. I think that's a really important issue. Carl, I bet you want to speak to that. In other words, are you saying that people who have advanced degrees are calling themselves community health workers very commonly or something? Is that what you're saying?
Oh, yes. We have nurses in our state, and it could be a population because we people that are applying for the jobs, I think sometimes the agencies may not realize, what they want the health worker to actually be doing, and then they see a nurse or someone professional apply. Well, I think, gosh, I don't have to pay them as much as I do for their nursing skills. But that's really not the true essence of what a health worker
Wow.
Sure. I would like to respond to that. First of all, the CHW certification requires a bachelor's degree, and most community health worker positions do not. So there should be clarity of expectations, the difference between the two of them. The National Commission for Health Educator Certification has expressed their support for the definition of roles in the CHW in the C3 recommendations. But I think the other point that's really important is that the community health worker may work in an individual or group setting, but when they're doing health education, they're almost always working from a standardized health education protocol or curriculum, and there are a number of those that have been developed specifically for use by community health workers. And they're in their role in health education, they are very much required to follow certain evidence-based methodologies. The CHW certified health educators may be more involved in designing health education programs, in evaluating health education programs and things like that. So I think it is a very important dialogue to have. And I wanted to acknowledge there was a question in the chat box talking about education level, and I think it's certainly not unheard of for community health workers to have bachelor's or even master's degrees. But as I said, most of the positions that are created tend to require perhaps a high school or GED, but not a post-secondary degree. So that's very, very important.
Yeah, this is Terry, and just to add to that, that's the reason why paying attention to the core, of this field, which has to do with being able to have peer relationships with people that they work with in low-income and marginalized communities, and to be able to have a shared background and to not be intimidating like, highly educated health professionals are. And so it's not to say that some community health workers may not, in fact, may have some professional degree. It's very important that it not be required, that it not block access to many people who would be very effective at this job in communities who don't have lots of education, formal education. So it's sort of understanding the core of this field.
Sure.
Hi,
we have a hand raised from Amy Scott.
Oh, okay.
Hi. Go ahead and go first. I'll wait till you're done and I'll ask my question.
Thank you. Brenda, Nevada again. Sorry to interrupt. But I did want to add to that. I feel that part of this discussion is how can the state provide better support for those people who may not necessarily have a secondary degree, or even to provide the trainings in the native language, for example, in Spanish. Our state, we work with a lot of traditional community health workers who are people from the community who know and understand, who are able to disseminate the information. However, there is a lack of support for an official training because they don't offer the trainings in their native language, or you do have to have, when they're looking for positions, like they may require a bachelor's degree and that sort of stuff. And so for people who come from other countries, they may not necessarily have that, but they don't have the support to get them trained into a community health worker.
Great points. Thank you. Amy, are you still there?
Yeah, I just muted. This is Amy Scott from Reno, Nevada. So addressing when you're talking about higher levels of education. So for me, I'm 50. I started off being homeless, so as a youth and in high school. So I've made myself up to where I'm doing an internship right now at a master's program at a Community Health Alliance in Reno. So as far as taking the background and understanding and also self-promoting people to empower them, the way that it was just being discussed, I just want to put out is that you do have people who can raise themselves up and be empowered with resiliency and having the exposure to individuals who have that life experience. So I'm not Hispanic, but I grew up in Watsonville, California, agriculture migrant workers during the Cesar Chavez migrant movement. And so I have a cultural understanding, but I don't speak the language. I understand enough to get myself in trouble, but to be aware of, even if someone is educated, that they may have a background to, and I learn from people, so having that interaction and having conversations, not dictating information. And I understand that the role needs to embrace and empower community level interaction, but to not, if someone has a degree and they're willing on doing that position, to not push away from that active involvement, because there's probably a story behind it.
That's right. I'd like to address this and just say that there are a lot of shades of gray in these discussions, and the kind of experience that you were just describing for yourself is, it speaks to a deep understanding of community-based issues. We have CHWs of color, say African American CHWs, who also serve people in the Latino community, or vice versa. And so to say that a CHW has unique understanding, often shared culture, typically comes from the community they serve, does not draw hard, bright lines. And these decisions are made by employers as well as certifying entities. This discussion about certification focuses on the role typically of state health departments, not exclusively though, as we'll talk about a little later in the call, in setting up certification programs. A public authority is setting up some definition, and that definition we think should be grounded, and typically in states it is grounded in this core understanding of CHWs coming from and understanding the communities and people they serve. That's different than the decision that an employer makes about whether or not to hire somebody. And similarly, when we get into the discussion earlier about education, a certification program under public authority has to make a decision about whether there are educational credentials required at all. And in Massachusetts, for instance, a CHW can be certified without any educational requirement defined at all, not even a high school diploma. An employer may make a different decision, but we stress that deep understanding of the community, deep understanding of the issues that the CHW is going to be working on are ultimately what's important to their effectiveness. So it's important to be clear about who's defining education requirements and in what context.
Hi, this is Kathy Karsting. Can you hear me?
Yes.
Yes.
My question is in the chat box, and it's to invite the speakers to talk a little bit about the level of independence or autonomy seen among community health workers. My thought is that community health workers ideally are at their most effective as respected members of integrated community-based care teams, and yet I rarely see sort of the team context for community health workers, or even the supervision model that might be necessary as community health workers face complex problems as they're working in the community. Could you discuss that a bit, please?
Yes, we think this is such an important point that we have set up an entire webinar to address it, Kathy. And today's webinar, I should have said at the outset, today's webinar is the first of three that are being provided to the learning community and their partners. The second one will be held in August, and I don't have the schedule right in front of me. We'll get it and share it before the end of the call. It will focus on defining CHW value, especially in the context of health reform and health system transformation, and addressing issues of CHW financing. The third webinar will address issues of CHW integration into care teams. And we will present a continuum of approaches that are being used now and advocate for integration, and I think much the terms that you just laid out.
Super. Thank you.
Other questions? Other comments?
Hi, this is Steve in Nevada, and I wonder if you can speak a little bit to, we've kind of talked about the continuum of education as far as it relates to the, closeness to the community, and how, peers of the people that we're trying to reach, as they get more and more certification and skills, they're kind of definitionally moving away from that peer status. But I wonder if you could address the economics a little bit too, about the more certification and skills that are required, and maybe you're going to address this in the financing webinar as well, but the more requirements we put on people to be able to do this work, the more expensive they get, and again, the more that they kind of definitionally move away from from being peers of the people that they're trying to reach.
Great point.
Great point, and the source of a lot of discussion that goes to the heart of whether credentialing of CHWs is a good idea, whether it's valuable, whether it will set up unintended negative consequences. We are going to address this in more detail in the second half of the webinar. So if you don't mind, I'd like to hold off on that and come back to it.
Great, thanks.
Yeah, thank you.
Jeff, I'm not sure how we should proceed. I see at least one hand raised in the participant list, and several questions in the chat box.
Yeah, I see. Norma, Marty, is you want to get in on this?
Yeah. Hi, I'm Norma Marty. I'm in North Carolina, and I think the issue for me continues to be this tug between community connectedness and position duties as assigned by the employer. And, again, that concept of independence and autonomy, it's, you can't do your work 9 to 5 if you're a community health worker. I can't imagine one doing that in any position that they may be in. So when I meet my friends who are patient navigators, they're working in the hospital and they're helping the patient in and out of the hospital system, work. But the more they do that, the less they know about what's happening in the community in terms of social determinants of health. And so,
Sure.
It's this kind of continuous tug
Right.
of
Yep.
of war, I call it. And
Yeah.
if the person who's hired as a patient navigator is part of a team in a community-based organization who manages and supervises, then to me, that continuity exists for that person to be connected, even though they're really specializing on oncology or diabetes or whatever it is that they're doing in the clinical setting with that team of experts. But again, it's a team thing, and I think we have a big potential. And I speak this from my own position as a community health worker, that we have a big potential of losing the connectivity to the community. I have to do things with my community that my employer probably doesn't see as job related. But in order for me to be effective in that community, I have to be there when they do things that are not necessarily job 9 to 5 things. But so that's it. I'm sorry.
I'd like to take that one. This is Carl. Thank you, Norma. That you speak to some very important issues related to. Part of it has to do with the community health worker training, and I'll come back to that. But we will get into more of that, as Jeff said in the third webinar about integration, because that speaks to educating the other members of the team and especially a direct supervisor about what the community health worker is supposed to be doing. If that team is not well prepared, and the community health worker needs to be prepared for the expectations of relating to the team, of course, but the team members need to be aware that to do the job effectively, you do need to be out in the community. And there are plenty of anecdotes out there, for example, of a health system employee who hears a community health worker on the phone in the middle of what sounds like a social conversation, and they might raise the issue with the community health worker's supervisor, not realizing that relationship is so important to the work of the CHW that their conversations with, if you want to call them clients or patients, that's fine, but their relationship with those clients or patients is going to sound different from the relationship of a clinical professional with that patient. So it may very well sound like a social conversation. So, but the other point, back to the basic preparation of the community health worker for their role, is they may have a natural appreciation of this, but it's really important to reinforce that their job day in and day out, you're absolutely right, it's not 9 to 5, but their job day in and day out is going to be balancing their task responsibilities with maintaining and building relationships. They're going to be doing a balancing act like that all day long, 24/7, that if they spend too much time on relationship, they're not going to get the results that they're supposed to produce.
That's right.
If they spend all their time on results and getting their numbers, that their relationships in the community will suffer. And so it's a really challenging balancing act, and one that everybody else in the organization needs to respect how hard that can be. So I'll leave it at that. But you raised some very, very important points. Thank you.
I'm going to take this forward now because time is flying by. It's amazing to me that we've already spent the best part of an hour. I just want to acknowledge, I see a question from Dominique Jones about payment structures, and we will get into that in some detail in the second webinar on August 2nd. It'll focus on financing. There's an issue raised, that question though, about the relationship between payment and integration within clinical practice. So let's make sure we'll come back to that. Similarly, there's a question from Shermay Richards, about licensing and relationships between CHWs and other licensed professionals. So we're going to get into that in the section of the webinar coming up right now. We're going to focus now on credentialing, and there are various forms of credentialing, and so we're going to draw some distinctions between licensing, for instance, and certification. And there are nuanced differences involving accreditation and certification. there's been a lot of discussion about CHW credentialing. I think generally speaking, the move towards certification, while controversial, has been spurred in large measure by CHWs themselves and CHW leaders who have wanted to be recognized and respected within healthcare and public health systems as professionals. And so there's a drive towards increased professionalization of this field, but with some important characteristics. And the question earlier about, well, you know, do we risk, through professionalization, do we risk CHWs moving away from the very communities that they're serving effectively now? So let's get into that. Terry's going to start us with looking at some context for professional development. And I want to just say to my colleague presenters, let us kind of go as quickly as we can through the slides to leave as much time for discussion as possible.
Yes, I appreciate that point, Jeff. I agree. So I think if you look at, if someone will move this slide to context for professional development for community health workers. Well, really, this is just a history of sort of the development and acknowledgement of this field over the last few decades. And I won't go item by item to save time, but you can see, if you take a look at these categories on the first page, or these points in the history, that the field started out in sort of issues of equity and during the war on poverty, and, you know, reaching out to and trying to bring greater equity and empowerment to marginalized and low-income communities. That's the history of the field. Its origins in the U.S. and plays a similar role internationally. And then, of course, what began to happen in the 90s and moving forward, community health workers at the national level started taking charge and coming up with the titles, and the APHA, Public Health Association, has played a big role historically as a national community health worker organizing and promoting entity. The APHA resolutions have also, you know, promoted the field in key ways, and most recently promoted the idea that community health workers need to play leadership in setting the standards for their field. Other milestones, the IOM Health Disparities Report. There are some national workforce definitions that have come to the fore, some of you may be aware of. Going to the next slide, you know, and then with the advent of the Affordable Care Act and defining community health workers as professionals, and a whole range of federal health reform-related changes that really called attention to this field and increasingly brought them to the point where, if you look at some of the post-ACA projects, you know, the CDC's promotion of coverage of preventive efforts by health plans and health providers, a lot of the innovation models and delivery system reform programs and demonstration programs from the feds have involved community health workers. And so now that has led to this increasing employment of community health workers in health-related work, in health institutions of a variety of kinds, and brought them from strictly community-based, sort of doing health equity work, to a much more diverse role in the whole range of related systems, and of course brings us to the point where a lot of states are looking at the credentialing issue. That's next slide.
Thanks. So, Kyle, you want to take us into this a little bit? You on mute?
The map.
Kyle?
Yes, I was on mute. That there are currently 8 states that have implemented certification. In a couple of cases, these are not fully implemented yet. But in approximate chronological order, these would be starting with Texas and Ohio, then Massachusetts, Florida, Arizona, New Mexico, Oregon, and Rhode Island. This map is the one that's on the ASTHO website, and there are several other categories I won't go into here, but ASTHO has been tracking this very diligently for a while now, but also the CDC and the National Academy for State Health Policy have been tracking it as well. So there is action going on in most of the other states. at least doing background research, if not actively considering certification. So I will turn this back over to Terry about the process of developing certification.
Actually, to Jeff.
That's to Jeff, yeah.
I'm going to take it for a few slides.
Okay.
So, picking up on this map and the fact that a number of states are considering CHW credentialing programs, certification programs, we want to offer some guidelines or recommendations. And as we've talked with each of the 5 states in the learning community, we've been emphasizing these. But we also want to make sure that since there are stakeholders from various sectors on the call, that CHWs need to be involved in helping to define the policies and processes for certification of their field. It would be inconceivable for any other profession not to have members of the profession involved in defining terms and defining protocols, procedures, requirements, etc. So that has been done in most of the states that have certification programs, but not all of them, and we see various approaches being used. So we're providing a lot of information and hopefully useful guidance to states about the importance of involving CHWs. It's also important for stakeholders from different sectors to define and agree on the rationale and objectives of a certification program, because there are so many different terms and there are so many different understandings, and it's so easy to confuse or conflate the difference between certification programs that are sanctioned by public authorities on the one hand and employment of CHWs in a whole range of fields. As Terry laid out earlier, while CHWs and this whole discussion is focused on the healthcare system, and CHWs are being used increasingly in integrated care teams within health settings. CHWs work outside the healthcare system too. They work in public health, they work in public safety, they work in housing development. So it's really important to be clear about what people mean, what they want, what they think certification means or doesn't, and we're going to go into that in a little more detail. We also think it's really important to have a responsive certification program to avoid the negative unintended consequences that can come with over-medicalization or over-professionalization. So we're going to get into that in more detail as well. In Massachusetts and other states, I'm particularly familiar with Massachusetts, there was a process that went on for a year and a half with CHWs, employers of CHWs, and payers, all at the same table in a formalized advisory group that was created by the legislature or sanctioned by the legislature. They came to common consensus. All 3 major stakeholder groups felt strongly about the importance of CHW certification, but they had different concerns and issues. CHWs may believe that certification will have the positive consequences of improving their compensation and working conditions and increasing respect that they get from other professions. That it will lead to more stable employment. So much of CHW funding is soft money, grant funding. The funding ends and the jobs go away. And that certification would help build professional identity, unification of the workforce, and consistent standards. So lots of positive hopes pinned on CHW on certification by CHWs, but also some concerns that certification may create barriers to entry. Might create a class system with certified CHWs being more highly valued than CHWs who are not certified. That maybe certification will lead to more clinical use of CHWs, medicalization of the field, less connection to the community. That certification could end up regulating, restricting, or changing what CHWs can do, or that it could lead to employment of people without strong community connection, people who go through some program that maybe a community college sets up. They come out with a CHW credential or degree regardless of where they come from. And that certification could further marginalize volunteers. So these are all really important, hot button and legitimate issues. Most of them can be addressed through a careful, responsive certification program. Certification programs that states are setting up can anticipate and respond to and mitigate these, or they can reinforce these and exacerbate them. So the guidance that we're providing is intended to, obviously, to mitigate and avoid these kinds of problems. Carl, you want to take us forward here into talking about this from the employer side?
Sure. And I think we've learned time and time again that it's important to get these beliefs out, or expectations out, early in the process, because I've heard from a number of states that as they began to engage more stakeholders in the process, they came with, you might call, baggage related to their beliefs about this that set the process back. And so encouraging people to, as we would say in Texas, check your guns at the door, to really articulate what your beliefs or expectations are early in the process can save a lot of heartaches. But in the case of stakeholders such as employers and payers, they are looking forward to seeing a clearer delineation of scope of practice between CHWs and others, that they can look to certification as assuring the qualifications of people that they are looking to hire, that it might make it easier to recruit and hire the right people, create more of a real job market, that certification, the folks who come with certification may require less in the way of on-the-job training, and that this can help them articulate the case for integrating CHWs into care teams. And as Jeff has said, that the connection to financing, which we'll get into in the next webinar, will that they expect that this will be a necessary step. And I think there is a fallacy in thinking that community health worker certification will automatically accomplish any of these things. That we've found that it doesn't change things unless other changes happen in the systems that affect the employment of CHWs. Likewise, if we're talking about negative beliefs, things that folks are concerned about, these are all legitimate concerns from an employer's point of view, that certified community health workers will expect to be paid more, that nobody in business really is a big fan of new regulations and so on, that they may have an increased expectations of paying for formal training of their workers. And many employers are sincerely concerned about community health workers losing that common touch. But one of the beliefs that we will, and I believe we go to it on the next slide, is that somehow certification, and this comes down to beliefs or expectations about what certification means and what it is, that it will sharply restrict the practice of community health workers. So just to get on the table, that certification, and we've talked about credentialing, we use the term credentialing, which is a broader term. The states that have implemented certification, certification so far is the only form of credentialing that has been implemented. And it is generally a voluntary measure, meaning that it's not, CHWs are not required to become certified in any sense. So it is, the certification is simply whoever issues the certification is saying, we believe this person to have the necessary qualifications to be, basic qualifications at least, to perform the duties of a community health worker. It does not have to be regulation of practice, but we found that in the case of one state, which will remain nameless, this sort of thing was managed by their Department of Education, and they were responsible for a number of occupations called certified thus and so. However, when you look at the details of their procedures and regulations, it was licensing. The language is all about licensing and saying you may not do these things unless you're certified. And so there are people who have preconceptions about this, definitely, that need to be clarified. That certification does not have to limit who may do the work of a CHW. And in the case of the states that have done certification, they do not limit who may do the work. Okay, they only limit who may use the title of certified community health worker. Secondly, that certification is not the same as a certificate you get from an educational institution for completing a workshop or a certificate program. However, in some states, they are at least considering saying that if you receive an educational certificate meeting these standards, that will be considered the same as certification. That's one of many options that the states have to include in their system. Lastly, a lot of folks assume that certification will be issued by the state government and usually the state health department. That is not automatically the way it has to go. And in fact, at least 2, probably 3 of the states that are implementing certification now, the issuing body is not a state agency. And so the state may recognize the certification, but they don't administer it or issue it. So the issuing authority could be a number of different options, including, as I said, an educational institution. In the case of Arizona, they want the Arizona Community Health Worker Association to be the body that issues the certification. This is a bold step, and this is the first actual circumstance of that we have seen. So I will now turn this over to Terry to continue the topic.
Thanks, Carl. So moving to the next slide, which talks about some general options that you think about at the beginning of making decisions about what kind of certification you're going to promote. The major certification options, these are not mutually exclusive, by the way. For example, pretty much all of the certification programs that exist now statewide for community health workers do certify individuals who work as community health workers. That's pretty basic, and that means that they've got a portable certification that's not tied to a single employer or organization. And of course, as Carl just said, the immediate decision has to be about whether this is a mandatory certification for community health workers or voluntary certification for community health workers, which are called title or practice certifications. And as Carl also said, generally speaking, the best practices really adopted by all states so far is that this is not a mandatory certification. You don't limit the people who can do community health worker work if they don't get the certification. And then, of course, another common certification option that has been adopted by, I think, perhaps all of the certifications so far, correct me if I'm wrong, Carl, that's been put into place, is to certify or authorize or accredit or approve in some way. The certifying body approves the training programs that can train community health workers and prepare them for certification. So that's part of both individual and training program certification is very common combination. Less common, but still adopted by a couple of states, or at any rate one I'm aware of, is that you can certify the instructors that work in community health worker training programs. I think this is true in Texas. In fact, I think they're required to be certified by the process established. Yeah. And in Massachusetts, they have developed a certification for community health workers who are working in training programs for community health workers. It's not and I don't think it's required for their actually doing that work, but it is an option for them. That's an occupational option, which gives them another job opportunity to be.
It's also a requirement for certified.
It is compulsory. Okay.
Yeah, I just want to add, it's also a requirement for certified training programs that they have to hire CHWs as trainers.
Right, that's right. And then I mentioned it a moment ago. It started out on this slide, and then somehow it mysteriously disappeared, but we wanted to make sure to mention that almost all states, many states have discussed, but none have adopted the option of accrediting employers or particular programs so that, the program and employer, which is not a bad idea, we all agree, because obviously the way you do these programs is just almost as important as the kind of preparation that community health workers have themselves. So you could certify programs or employers who have everything in place to do a best practice kind of community health worker program, but no one has gone for that so far, and it's possible just that it doesn't allow for the flexibility that community health workers need to have certification go with them from job to job. So the next slide, the basic components of an individual community health worker certification program, it's just really getting at what you need to have as part of your whole program. It's pretty basic stuff. You have to determine who has the certifying authority, what organization, and where it will be located administratively. Very often it's in state health departments, but by no means all the time, as Carl pointed out. You have to define what the certifying entity is and what it's, who needs to be a part of it, what kind of powers they have, and how they're going to operate. And in the composition, it's best practice, again, is to have at least half of the members of any certification entity be community health workers. Some states have less than that, but pretty much all states, I think, so far, most states have community health workers proportion defined as a part of that certifying entity. Of course, having a definition of community health workers and what the core competencies are and the scope of practice and practice standards, the eligibility for certification requirements. I think the rest of this is pretty clear, how you're going to assess eligibility and what the continuing education requirements are and all the procedures, including, renewing and revoking and expiring and appealing and so on. Next slide. And then a very important slide and a very important concept that both Carl and Jeff have talked about a lot, which is, okay, and some of you have raised questions about on this call, is the question of how you make a certification system responsive so that it doesn't doesn't result in unintended consequences for this field, because there's no point in trying to certify this actual field and all of its core strengths out of existence. It would be shooting oneself in one's foot, I think. So that means a number of the responsive features of a certification system would include having multiple paths to, getting certification, including one path which is called, the grandfathering/grandparenting approach, and I think all states do this, a path that's based on experience, at least for some period of years. User-friendly application processes and criteria so that language and education and even citizenship status do not present barriers to very promising and perhaps already very experienced community health workers to receive certification. Training being provided in accessible and familiar settings that don't pose cultural barriers and barriers of, that would discourage people, such as placing it in a university setting. Community-based organizations like community health centers and, public health institutions and also community colleges are very common, and that the skills be taught using methods that are, again, appropriate for creating the kind of practitioner that this field really requires. People being able to draw on their own experiences, the principles of adult education and popular education are very pervasive and should be in approaching the training community health workers formally. And having, as Jeff said, Massachusetts has required community health workers be part of the trainers in the approved training programs. Same thing with access to CEU and other kinds of learning, that increasing distance learning and some kinds of hybrid online learnings with some face-to-face contact, making sure that CEUs are located physically and culturally accessibly for community people, and making sure that certification does not marginalize the very important historical role of community volunteers as community health workers. Next slide. Carl, I'll hand it off to you. Carl? Carl?
And again, unmute. Okay. So given all of those things and the features of a system that need to be considered, we've learned from experience in a number of states what some of the issues are that are really crucial to get the results that you want from certification. One is to do a very thoughtful job of defining the core competencies. And there are resources to help you do that. The early states that started with this relied on the National Community Health Advisor Study from 1998. The environment has changed somewhat since then. So there is increasingly some commonalities in the core competencies required by various states. In addition to the option of grandfathering or grandparenting, work experience as part of the certification requirements seems to make a lot of sense, that community health workers need to be observed or assessed in terms of their proficiency in a work setting and not simply in a classroom setting. So there are some decisions about the grandfathering or grandparenting. Will that be permanent as it has been in Texas, or will it be available only for a time-limited period after which everybody has to go through the training? And so thinking about is the look-back period that is permitted for grandparenting. The training requirements obviously have to be considered in some detail. The good news is that there are more examples now of really good training programs that can be emulated. Education requirements, we've talked about this earlier in the webinar in some detail, that most of the states require high school or GED, in some cases not even that, but that it does not appear appropriate to require a 4-year degree for certification of CHWs, because then you're talking about overlapping with the educational requirements of something like CHEST certification, which we really are not trying to do. But it also means we're trying to really value as heavily as possible the life experience of the people who come into the work. Continuing education, as Terry pointed out, that's part of the basic features, but it is a crucial issue in the sense that, just as an example, in Texas, the first state to establish certification, the accessibility of continuing education hours, CEUs, was very limited, and so we had a phenomenon of people who were becoming certified but were unable to renew, and their certification lapsed because they couldn't get access to approved continuing education hours. Language and citizenship requirements, think about those very carefully. One of our callers, one of the participants on the webinar, talked about access to training and certification processes in appropriate languages. In Texas, the application process is available in Spanish and English. In Texas, which is not exactly the most progressive state in the country, the application does not require disclosure of citizenship status or social security number. And that doesn't mean that folks who are undocumented trust the state any more than they did before this was established. But at least there has been a step in that direction. some more issues that are important is how do you do the assessment of qualifications? There's been discussion. Some states have talked about having a written exam. I think that should be considered very carefully, given that the folks who have the right stuff to be good community health workers may not be the best test takers. And further, that written exams are appropriate probably for tests of knowledge, but are not very reliable when it comes to assessing skill proficiency. But just how do you go about assessing, and the jury's still out on how best to do this. How do you make sure that people have the right stuff in terms of connectedness to the community and credibility with the community, commitment to the community? That's a big challenge. How do you incorporate that into a certification process? And there have been different attempts at approximating that. So that's certainly one to consider carefully. One of you on the call has raised in writing the question of reciprocity. We don't have that yet in the states that I'm aware of so far. Ohio had in their original system a provision for reciprocity where certification from another state would be accepted in Ohio, and they subsequently repealed that. And I'm not real clear on why they did that. But the other states have not done that yet. But it is clear there's going to be pressure in the future to establish reciprocity between states, and the more we can make the standards similar between states, the easier it will be to have reciprocity. Background checks are a controversial thing. A number of the states with certification require a background check as part of certification. It has always been I've raised this question a number of times, but most employers consider that it's their responsibility to do background checks, and they probably will do it anyway. As to why that needs to be part of certification is certainly a legitimate question. And there are some very successful programs. For example, some of you are familiar with the Transition Clinics program, which specializes in formerly incarcerated individuals as CHWs working with formerly incarcerated individuals. And I think we can all see the logic behind that. But background checks, if they were strictly applied, would make that very difficult. And then lastly, which would be true of any system like this, how do you make a complaint resolution process user-friendly from both the employer's point of view, the community's point of view, and the community health workers' point of view? So I'm going to hand this back to Jeff to wrap up. And Jeff, are you on mute?
Yes, I was. Thank you, Carl. So we're just going to have a couple more slides, and then we'll open this back up for conversation. I want to briefly cover some issues to consider for the certification of CHW training programs, and also some issues involving the administration of CHW certification. There are a lot of questions involved in if you certify training programs, which is not required, then what model of training do they provide? Are they certifying organizations? Are they certifying individual trainers? Are they certifying both? New Mexico, for instance, certifies individual trainers for their competence to deliver a state-sanctioned standard curriculum. Most states use a different model than that, but there are options. Requirements for CHWs to serve as certified trainers. So we would be concerned about CHW training that doesn't involve CHWs among the trainers. The various organizational issues. Who's providing the training? Are they fiscally solvent? Are they well managed? Is there any legal integrity? The issues that this is concerned with controversies involving technical training, industrial training for profit, and there have been some pretty disastrous experiences with these for-profit entities that pop up, offer to certify people and train them, and then don't run away with the money. So as training expands, we probably need to look at that if it's from a state perspective. Again, if the training entity is part of a larger organization, is there a good mission fit with that organization? Work is all about. What's the training curriculum and program design? Does it, for instance, use popular education models? Does it conform to help address the core curriculum, the core competency issues that Terry was talking about earlier? What are the qualifications and experience of the trainers or the faculty? Can just anybody hang out a shingle and start calling themselves a CHW training program, or in your state you want to set some requirements around that? How do you evaluate the effectiveness of training? A lot of states are basing their certification after grandfathering on experience plus training. And there's a presumption that if you go through a certified training program and you meet the work requirements, then you get to be certified. Well, how do we know these training programs are doing a good job preparing people for mastery of the core competencies? What kind of reporting are they going to be required to do to the certifying entity? What accountability is there of the training entity to whoever certifies them? And finally, that, of course, raises a host of issues for state health departments or other entities that may be actually administrating these certification programs. Most important is who is the certifying entity. If it's established in statute that it's the state health department, where is it based in the state health department? If it's not in the state health department, is there a relationship between public authorities and the private organization? What is the private organization, et cetera? Are CHWs engaged in developing and monitoring the program? We say emphatically they should be. What about engagement of other stakeholders, employers, payers? How are they involved in monitoring and certifying, monitoring programs developing? What communication and other protocols do you establish to make sure that there's good coordination among responsible entities? That's not only true for certification in states like Florida that have a private entity doing the certification, but in close cooperation with the state health department. Obviously, you need strong communication there, but also within state health departments. If you have a Division of Health Professions licensure, for instance, responsible for administering the program, but program expertise is lodged in a Bureau of Community Health or Chronic Disease or some other kind of division whose managers and staff are really the ones who are experts on and closest to CHWs. How do you coordinate? What's the capacity for assessing individual and training program qualifications? Carl got into this earlier. You know, we generally discourage using exams. They may be appropriate for assessing whether CHWs understand HIPAA, for instance, a very specific knowledge-based question. But what do you do to assess mastery of the core competencies? There are models out there that you can use, and we can share information with your individual states if that may be helpful. And similarly, how are you going to administer continuing education, keep track of the courses that people take, keep track of what courses will satisfy continuing ed requirements? Do you have the administrative apparatus in place to process renewals? 2 years is often the time limit on certification, so you've got to be ready almost before you begin to renew people. Keeping track of grandfathering as well. If you have a liberal approach to work qualifications, look-back periods, et cetera, you got to have people in place to make sure that you can process those applications as they come in. And obviously funding and financing, not only for CHW work in general, but more specifically in this case, making sure that you can sustain the costs of administering the program at the most reasonable possible cost, if CHW fees or employer fees for CHW certification is funding the program. We don't want the cost of certification to put it out of reach. All right, we have said a lot, and at this point we want to open it back up for questions. And some of these have already come in. So we have some questions that we put down, but I'm actually not going to start with these. Instead, I'd like to invite some of those of you who have raised questions in the chat box to raise these. So, Linda Lang, are you willing to unmute your line and ask your question?
Yes, I am here. My question is, could you provide any information that you have on the ICNRC Community Health Worker Certification Pilot Program? It was my understanding that, I cannot remember the state, but maybe Rhode Island or someplace out east was piloting the ICNRC. And our state currently uses the ICNRC for all of our drug and alcohol, and in the last year for peer certification, peer specialist certification, and prevention specialist. So I was just wondering if you had any updates on that program.
Carl, do you? This is Jeff. I unfortunately do not. Terry or Carl, do you?
I'm afraid I don't either. Do you? Can you at least tell us what the initials stand for? It might help me recall.
Oh, I'm sorry. It's the International. Oh my goodness, you're going to put me on the spot here. International Certification and Credentialing Consortium.
Never heard of it.
So you win a prize, Linda. You have stumped all three
Stumped
subject
the panel.
And it's obviously something that we should look into. Sorry, we cannot help with that right now.
Interesting. Can I ask real quickly, I don't want to monopolize this, but can I ask the other states that are on the line? It's my understanding that the prevention certification is in, we were the 49th state to get prevention certification and like the 20th for peer. Do any of the other states on this line, are you aware of the ICNRC and their involvement in your state?
Perfect question. Anybody unmute your line if you can shed any further light on this?
Okay,
all right, Linda,
I'll let you guys move on.
We have to credit you with being distinguished nationally as out ahead of the curve on this particular point.
Not so sure about that, but thank you.
We'll certainly look into it further. That's helpful.
Can you hear me? Can you hear me?
Yes.
Oh, okay. I think I was on mute. I did just Google that, and the ICNRC is International Credentialing and Examination for Prevention, Substance Use, and Recovery Professionals. So it's generally speaking not been part of the way community health workers are prepared for their work, because that kind of work has evolved in connection with other federal and state agencies. But I will say that increasingly community health workers are receiving some kinds of trainings related to substance use and recovery, but it's not part of their core training at all.
I
would say further
clarify
that,
real quick, and then I'll just let it go, is that they've actually added, it's way beyond that, they've added a law enforcement certification, they've added a peer certification, they've added a mental health certification, and now they're looking at community health workers. So it's a little broader if you dig deeper in the website. So it's just something we should look at as we move forward as a nation for consistency.
Just to add briefly, there are a couple of states that have linked community health worker core training to peer support specialist training. In Indiana and Washington, I believe that the individual goes through the CHW core skills training and then becomes a peer support specialist by taking another block of training. Whether that is officially, I can't say officially whether that's recognized by the state yet or not, but that's another way that some states are looking at going.
Yeah, and this is Terry, and I would just add that we are seeing more and more community health workers receiving recovery coach training as well, but that, again, would be on top of their core competency training and experience.
Okay, we have other people who have asked questions in the chat box. Tish, do you want to state your own question?
Sure, I'm more than happy to do that. Hi, I'm Tish Singletary with in North Carolina, and my question was around, and I think Carl kind of answered it anyway when I was listening to some of the discussion, but are we getting any closer to any kind of national standard for the core competencies for community health worker? I know this consensus project is kind of leaning in that way, but do we think we'll get there at some point?
It's a great question, and the intent of C3 is to promote dialogue primarily at the state level about what all of this ought to mean, and we would like to see states at least start from the same point in terms of thinking about.
Hello?
Carl? It sounds like we lost Carl.
Really?
So
Yeah, we couldn't hear you.
Can you hear me now?
Oh, good.
Can you hear me now?
Yes.
Okay. Frankly, there are folks around the country who are wary of the idea of any kind of a national certification. So it is not something that people are actively pursuing right now. There is, however, an effort underway to create a national network or association of community health workers of some kind, and that's showing some promising progress. If there are to be national standards promulgated, my personal belief is that would be the organization that should put them forward. But they are not at a stage now where they can look at an agenda like that, because it's a pretty tall order. So it's not clear that they will take it up, but if there are to be national standards, that would be the first place I would look.
Okay, thanks. And I think the other reason why I asked the question was because if you're thinking about reciprocity amongst states in terms of community health workers being able to move from one state if there's supportable training, if they're getting their individualized training, I think you have to have something that somehow that everybody agrees that this is what reciprocity means. So there has to be some national something. That's where I'm.
Sure, of course, yeah. Of course, it's taken a long time to get for even like physicians to get to a stage for reciprocity, but it's an excellent point.
Thank you.
Kathy, Karsten, you have a question here. Do you want to state it yourself?
Hi, thank you. Yes, I actually just was sort of mulling over the conversation about test-taking methods, adult learning, practical learning, and so forth, and then remarks about test-taking, and just found myself mulling over expectations of community health workers around performing health screening and presumably interpreting results and carrying out appropriate health training or education for participants. And I guess in part of conversations that I've been part of here in Nebraska, just kind of mulling over how it is that we navigate sort of our understanding of those folks that are in touch and well integrated with the priority populations that we're trying to reach that might not be English speaking or highly literate in sort of our usual traditional thinking of the phrase, and yet at the same time thinking about community health workers who are prepared to report out or interact with members of the healthcare team or folks that are using electronic records. So just kind of a mulling over a little bit if speakers have more comments or others participating in the webinar about just sort of navigating or thinking about the basic literacy, written and oral communication skills that are appropriate for community health workers, and yet, as discussion has gone on this morning, those qualifications or expectations don't reach such high levels that we're closing out the people that we really want to be working with us as community health workers. So I don't know if there are more comments about that, but just that we've had conversations here about what should we be expecting or looking for as far as functional literacy, written and oral communication skills, English language skills sufficient to sort of cross over into healthcare professionals and healthcare teams in order to achieve the population health outcomes and individual health outcomes we're looking for. So thanks.
This is Jeff. I'll start us off, and I assume that others may want to speak to this. There are a couple questions embedded in this. One is English language or other kind of literacy and educational requirements. The other is facility with specialized practices and training, appropriate assessment protocols for doing that. So I would say, with respect to that second point first, employers, we need to distinguish that a certification program is generally based on certifying that an individual has sufficient mastery of the defined core competencies of CHW work. And there are a lot of training programs that also provide specialized training in prevention and care for people with diabetes, for instance, or asthma, or cardiovascular disease, or cancer, et cetera. Maternal and child health specialization. So there's a lot of specialized CHW training out there. Employers also, of course, do their own on-the-job training. And there may be different kinds of assessments and even tests appropriate for certain aspects of care, including the kind of example you gave for making sure that a CHW is prepared to contribute properly and effectively in an integrated care team setting around certain kinds of diseases or conditions. With respect to educational qualifications, it's a touchy one. I'll say that we looked, and I'm speaking now as the former chair of the Board of Certification in Massachusetts, we looked very hard at this. And we were originally expecting to at least require a high school diploma. But we ended up not doing it, and it was interesting. It was actually community health center officials who were very persuasive in the discussion, and one of the board members from a community health center cited the case of a Hmong CHW who was not fluent in English, did not have a strong English language capacity, and they had to have an intermediate translator for that person. So there were two levels of translation so that person could communicate back with the English-speaking team. But she was so effective in working with the Hmong community that to have lost her would have been a tragedy. So we agreed, okay, employers should have the flexibility to figure out those kinds of protocols on their own. And ultimately, the capacity to perform the core competencies with the community to be served is what should dictate in a certification decision. That's one state's approach, but those are the kinds of considerations that can be made in certification programs to take into account the danger of unintended consequences that could be unnecessarily restrictive.
This is Carl. Building on what Jeff said, I want to pick on one particular part of the question having to do with the role of CHWs in participating in screenings, some of which may be an interview type assessment similar to taking a history, but there are certain screening tests like blood pressure, blood glucose, body mass index, things like that. That in some states this is perfectly fine for people to do, but I think you used the word in the question about interpreting results, and there's clearly a boundary where the community health worker cannot clinically interpret the meaning of results, but they may operate under a fairly rigid guideline. In other words, if somebody comes to you and you take their blood pressure and it shows it's over 140 over 90, let's say, that your protocol is to ask first, have you talked about your blood pressure with your physician? And because of the guidelines that we work under, we strongly recommend that you talk to your physician about your blood pressure. And that's it. They can't get any further into it than that. And because that would be any further stepping into interpretation can be read as diagnosis or practicing medicine without a license. So there is a lot of that. And I think one of the tests that people are applying to this at some point is to say that if this is a health screening technique that we expect consumers or patients to do for themselves. In other words, if you're dealing with somebody who's managing blood pressure, and you say, okay, you should be checking your own blood pressure at least once a day. Well, if the patient is expected to be able to do that, then I don't think it's unreasonable that a community health worker should be able to use appropriate devices and so forth to measure and simply report the numeric results to that individual or patient. So those are important conversations to have in your state. And a lot of when we get to talking about proficiency and doing things like that, it's probably not a written exam unless it's talking, as Jeff said, about HIPAA or testing knowledge about the guidelines. At what point of blood pressure do you recommend to the individual that they talk to their physician? That sort of thing. But the assessment of proficiency in taking blood pressure is a simple observational one. Show me how you're going to do it. And so these are important discussions to get into in your state.
I'm going to interrupt and say I'm looking at the clock and realizing we're close to the end of the webinar. So Linda Lang has a question. I'm just going to read it out in the interest of time, Linda. But are any states using a tiered approach to certification? The answer is yes. New Mexico, for instance, has several levels of certification. There's a basic level and then 3 additional tiers or levels of certification tied to the number of additional specialty training programs that CHWs have gone through. The New Mexico training regimen includes specialized training in the kinds of examples I offered: diabetes, chronic cardiovascular disease, et cetera. So if you have one of them, you're a tier level 1. If you've taken 2 of those, 2, et cetera. Massachusetts legislation similarly provides for tiered training. The state health department has decided at this point to pass on that. They're just going to start with a basic. So you could provide for it in a certification program without implementing it right away.
And this is Terry. I just want to add, can you hear me?
Yeah.
Okay. I just want to add that one of the considerations in thinking about doing tiered certification, however, and it's been discussed certainly in Massachusetts and other states, is, the challenge of providing levels of certification and at the same time the role that employers often prefer to create their own tiers and levels, so that it's just something to weigh when you're considering that kind of certification at different levels.
This is Carl. One small note adding to Jeff about New Mexico. The first specialization that New Mexico proposed creating was what they call clinical support skills. so that these would be attractive to employers who wanted to employ someone in a clinical setting. And that's certainly an interesting approach.
If there's a quick final question, we can take it. Otherwise, I think I'm going to start our wrap-up. And if you've got a quick question, feel free to interrupt me. But mindful of your time, I want to thank you again very much for joining us and hope that this has been very useful. Yes, you can. Linda Lang asks, can we get the PowerPoint? And the answer is absolutely yes. It will be distributed through ASTHO, and Anna Bartels has everybody's contact information. Anna, am I right in saying that you can send this out to folks?
Yep, we'll send it out right after the webinar.
Thank you very much. I want to remind you that this is the first of 3 webinars. The second one will be on August 2nd. It'll focus on the value of CHWs in health settings particularly, but also public health, and financing issues. And then we will continue with the third webinar 2 weeks later on August 16th, focusing on integration. You are welcome to join us for either or both, and I hope we've done a good job addressing your questions as we've gone along. We will similarly look to you to ask questions and share with each other in the next webinar. The less didactic we make this, I think the more helpful for you. So the more you bring to it, the less we'll say. And it's 2 o'clock. Thank you very much. Have a great afternoon, and hopefully we'll talk to you on August 2nd.
Thanks
Bye.
very much.
Thank you.